Let's take 100 people with a technical diagnosis of sepsis, and let's put them in a line. Let's sort them according to how ill they look. On the right-hand side of the screen, we might have a dozen patients who are extremely ill. They are so obviously ill that we almost don't need a diagnostic tool to tell us that these people have sepsis and we cannot wait before delivering antibiotics. Conversely, on the left-hand side of the screen, we might have a dozen people who have a technical diagnosis of sepsis but look much more well. They might be walking around, they might be talking on their phones, and we might think it's safe in those patients to wait before we intervene. These patients might not need antibiotics in some cases. And in the middle, we have perhaps 76 patients in whom we need to exercise clinical judgments to make the right decisions. Some of them will need urgent antibiotics, and some of them might not. The point with sepsis, though, is it's very difficult to tell which patients go where in this lineup. It would be convenient if we could tell. So we use tools to add to our clinical acumen to decide in whom we need to initiate urgent therapy. You might think that the old SIRS or systemic inflammatory response criteria were oversensitive, so they probably would initiate treatment for the patients at the very left-hand edge of this line, patients who might not need early antimicrobials. You may have heard of the new definition of sepsis, the sepsis 3 definition, with its diagnosis of sepsis being made by a change in the SOFA, or Sequential Organ Failure Assessment Score. And that's likely to capture every patient at the very right-hand edge of the screen, but might actually miss some patients in the middle who will benefit from early antibiotics. The reality is we do not know which patients in this continuum need early antibiotics yet. We suspect that in the future we will, and we will be able to individualise care. And that's why we at the Sepsis Trust initiated the concept of red flags. For two reasons. Firstly, because it's complex and difficult to make a formal diagnosis of sepsis using a change in SOFA score. And secondly, because it probably operates somewhere in the middle and is designed to pick up those patients who probably need urgent antibiotics. So we might capture more patients with red flag sepsis than the official diagnosis of sepsis, but we probably capture fewer than using either the National Early Warning Score alone or SIRS criteria. And that's why we believe that red flag sepsis is a pragmatic solution to make sure the patients who need urgent care the most get urgent care the fastest.